So I'm going to be talking about some of the antiplatelet medications that you're often going to be seeing in clinic. First of all, it's important to know that these antiplatelets medications obviously have an effect on platelet aggregation, and so it's important to know what platelets actually do. Platelets play a major role in hemostasis. So when a wound occurs, they adhere to collagen fibers of that wound, and then they actually become spiked and much stickier. They then release chemical messengers such as ADP, serotonin, Thromboxane A2, which in turn cause more platelets to stick to the area, and those platelets then again release more chemical messengers, enhancing vascular spasms. This eventually creates a platelet plug that then continues the process in kind of a positive feedback loop. Platelets are responsible for stopping the bleeding of unnoticed wear and tear of our skin on a daily basis, and this is what's referred to as primary hemostasis. There's actually a variety of factors that play a role in platelet aggregation, so things like collagen, von Willebrand factor, ADP, Thromboxane A2, stress, and thrombin. And what you're going to see is the antiplatelet therapy that we use is actually geared toward these triggers of platelet aggregation. Aspirin is perhaps the most common antiplatelet you'll be seeing. It inhibits a major COX product called TXA2, which is an inducer of platelet aggregation as well as a vasoconstrictor. It also blocks the production of Thromboxane A2 by covalently bonding to the active site on the COX. Now, it's important to note that platelets do not synthesize new proteins. And so what that means then is when aspirin takes effect, it takes a permanent effect. And so it will essentially take 7 to 10 days to overcome the effect of aspirin. Aspirin is often used in the prevention of myocardial infarction or the prevention of strokes. It's also used in peripheral vascular disease, percutaneous angioplasty, or prophylaxis of a thromboembolism in patients who have prosthetic valves. Now, in addition to aspirin, we also have a few other mechanisms for antiplatelet therapy. These are going to be your ADP antagonists, one of which is ticlodipine or Ticlet. Now, this drug is a prodrug. It's activated in the liver by your CYP450. It is rapidly absorbed and does have high bioavailability. It can take a while to inhibit the platelets using this drug, 8 to 11 days after starting therapy. Typically, we use it again for prevention of stroke in a patient who has unstable angina, and we can actually combine this with aspirin after angioplasty or coronary artery stenting. Some of the adverse effects of ticlodipine include nausea, vomiting, diarrhea, neutropenia, and thrombotic thrombocytopenia. Another ADP antagonist is clopidogrel or Plavix. The benefit of clopidogrel is that it tends to be less toxic and have less side effects than ticlodipine. Particularly, it produces less leukopenia and less thrombocytopenia. Now, clopidogrel is a thienopyridine. Prasugrel is another thienopyridine ADP antagonist. It works by irreversibly binding to the P2Y12 receptor, and generally, like clopidogrel, it's going to be more potent than your aspirin. Prasugrel or Effient is administered by mouth once a day. Generally, we start with a loading dose and then follow that with maintenance doses. It doesn't have the similar concerns of decreased efficacy in patients who are poor metabolizers or on current PPIs that you might see in other thienopyridines. Ticagrelor or Brilinta is another ADP antagonist. The benefit of Brilinta is that it doesn't bind directly to the site of the ADP. It's actually an allosteric antagonist, which makes its blocking more reversible than the other drugs that we've talked about. It also doesn't need to go through the liver in order to be activated, certainly working better for those patients then who have genetic problems with some of their liver enzymes, particularly CYP2, C19. There's also good evidence to show that Brilinta is a good drug to use in non-STEMIs, so non-ST elevation, acute coronary syndromes. In general, we tend to use Brilinta for the prevention of thrombotic events, things like strokes, heart attack, in people who have acute coronary syndrome or MIs with ST elevation as well. And generally, it's going to be combined with your aspirin, unless, of course, aspirin is contraindicated. Phosphodiesterase inhibitors are another antiplatelet therapy. This includes dipyridamole, which is Persanti. It basically works via inhibition of PDE and blocking adenosine, working at the A2 receptor. It's basically simulating adenyl cyclase, which therefore causes platelet inhibition. We use this drug along with warfarin in patients who need prophylaxis for thromboemboli, so patients, for example, with prosthetic heart valves. Finally, we have your glycoprotein IIB and 3A receptor antagonists. This is apixaban, which basically works by also, again, causing reducing platelet aggregation via an antagonistic mechanism to fibrinogen involved in Willebrand's factor. It is a monoclonal antibody that basically, again, blocks the receptors. And we typically give this IV. It has a short acting time frame as well, usually lasting about 2 hours. So it's typically more going to be used for your percutaneous angioplasty for something like coronary thrombosis. All right, and that is it for antiplatelets.